body. Welcome to number 1 Doctor Channel. Today we will talk about duodenal ulcers. From increased acid production and decreased defense. Most common peptic ulcer, more common in men. Usually in first part of the duodenum, usually anterior. Anterior ulcers perforate. Posterior ulcers bleed from gastroduodenal artery. Symptoms. Epigastric pain radiating to the back abates with eating but recurs 30 minutes after. Diagnosis. By endoscopy. Treatment. Proton pump inhibitor PPI. Omeprazole, triple therapy for Helicobacter pylori. Bismuth salts amoxicillin and metronidazole or tetracycline. Surgery for ulcer rarely indicated since PPIs. Need to rule out gastronoma in patients with complicated ulcer disease, Zollinger-Ellison syndrome, gastric acid hypersecretion, peptic ulcers, and gastronoma. Surgical indications. Perforation. Protracted bleeding despite EGD therapy. Obstruction. Intractability despite medical therapy. Inability to rule out cancer ulcer remains despite treatment. Requires resection of ulcer. If patient has been on a PPI, an acid-reducing surgical procedure is required in addition to surgery for any complications. Surgical options. Acid-reducing surgery. Asterisk proximal vagotomy. Lowest rate of complications, no need for antral or pylorus procedure, 10%, 15% ulcer recurrence, 0.1% mortality. Truncal vagotomy and pyloroplasty. 5%, 10% ulcer recurrence, 1% mortality, truncal vagotomy and antrectomy. 1%, 2% ulcer recurrence. Lowest rate of recurrence, 2% mortality. Reconstruction after antrectomy. Roux-en-gastro-jejunostomy. Less dumping syndrome and reflux gastritis compared to Billroth 1, gastroduodenal anastomosis, and Billroth 2, gastrojejunal anastomosis. Bleeding. Most frequent complication of duodenal ulcers. Usually minor but can be life-threatening. Major bleeding. 6 units of blood in 24 hours or patient remains hypotensive despite transfusion. Treatment. Upper endoscopy. First hemoclips, cauterize, epinephrine injection. Surgery. Duodenotomy and gastroduodenal artery ligation. Avoid hitting common bile duct posterior with gastroduodenal artery ligation. If patient has been on a PPI, need acid-reducing surgery as well. Obstruction. PPI and serial dilation initial treatment of choice. Surgical options. Antrectomy and truncal vagotomy the best. Include ulcer and resection if it's located proximal to ampulla of Vater. Need to take biopsy from area of resection to rule out cancer. Perforation. 80% will have free air. Patients usually have sudden sharp epigastric pain, can have generalized peritonitis. Pain can radiate to pericolic gutters with dependent drainage of gastric content. Treatment. Gram patch. Place omentum over the perforation. Need acid-reducing surgery if the patient has been on a PPI. Intractability more than 3 months without relief while on escalating doses of PPI. Based in EGD mucosal findings, not symptoms. Treatment. Acid-reducing surgery.